we're going to do with all of you. Disaster medicine may be a relatively new idea, new field to all of you, but as we were just talking about with a meeting with some of the faculty, it's really something that transcends all areas of healthcare and medicine, quite frankly, because, you know, a term that we use in the U.S. and I think has to be modified for here on the islands is that all disasters are local, which means in the first 48 to 72 hours after any disaster, don't expect to get any kind of organized outside help. It's really dependent on local resources. So for that reason, and also for what we has, you know, now found out has gone on in Puerto Rico, unfortunately, and I'm sure in some of the other islands as well, after the very rough hurricane season last year, this is really something that we as a healthcare body, as people, as healthcare professionals, we need to take ownership of. Traditionally, disaster medicine has been housed in emergency medicine, and I'm an associate professor of emergency medicine at Harvard. But it's really going beyond that now, because there are different aspects of disaster response and preparedness from the healthcare perspective that we just need to do a better job at, and it involves all of us. So we very much look forward to this center that we're creating in conjunction with AUC. We think this is an ideal spot for the region. There is no real organized system like this center will be in disaster medicine in the Caribbean. I think this will not only serve the university and the island, but I also think it'll serve the region. And we have really high hopes for this becoming a real force in disaster medicine in the Caribbean, Latin America, and elsewhere. So we're thankful to AUC for being willing to enter into a collaboration and teaming with us to do this. We think it's going to be an incredibly valuable resource. To give you a very, very brief overview, because you'll be hearing a lot about this, I think, in the coming months and years ahead as we build this. The idea of this Center of Excellence in Disaster Medicine, which is going to be established here, is really three arms. One will be an academic and training arm, where we actually, you know, we give courses, we do lectures, we do other things, training, workshops, and et cetera. There'll be a research arm, but then what I think makes them unique and importantly is that there'll be an operational arm. So this center will integrate into both island and I hope regional emergency preparedness infrastructure and become a resource for otherwise disparate agencies, let's say, to come together under one roof and talk about how we're going to respond to disasters, plan some things out, do some drills, do some tabletop drills, et cetera. So I think, and I hope that it's going to serve as a focal point for the operations of the island and the region. Of course, looking at things like, you know, hurricanes, infectious diseases, and some of the things that are relevant to the area. The center will then also join other centers that we're developing around the world as part of the Global Society of Disaster Medicine. We currently have centers that will be opening soon in Toulouse, France, and in China. And we have a number of other centers that we're looking at and in discussions with as of now. Having said that, we hope and we feel this center will be our flagship center, because not only will it be the first one established, but will also be really the only one in the region. We do not plan to open one of these in the United States, and we hope that this center will serve as our real focus and the, as I said, the flagship center of the whole network. So we have a lot of high hopes. I hope that we can integrate well into what you're doing, certainly involve all the faculty, involve students in some of this, and give you a little bit of a experience in what the breadth of disaster medicine looks like. So having said that, and just to introduce a little bit of what we do within our fellowship, and I always have to get my notes, because as much as a good friend Gavin is, he's got quite the background that I have to introduce. We're going to have our Director of Global Operations at the Fellowship, Dr. Gavin Macgregor-Skinner, give a talk now as sort of an example of some of the things that we do. He's an expert in a number of different things, one of which is the highly infectious diseases and some of the responses he's led for Ebola and other things for entities like the CDC and else in West Africa and elsewhere. So I hope this gives you an idea of some of the things that we can bring to bear to this partnership and this collaboration. So Dr. Macgregor-Skinner is Apt Associates Senior Global Health Security Advisor. He has more than 20 years of technical experience in infectious disease surveillance and response. He's worked on these issues with the United States and international governments, United Nations agencies, and the private sector in the United States, Africa, Asia, Middle East, and Latin America. He's an assistant professor in the Department of Public Health Sciences at Penn State Hershey College of Medicine, and has appeared on CNN, BBC, Canada, CTV, Australia, ABC, C-SPAN, and other news outlets to share his experience in global health threats. Prior to joining ABT, he served as Director of International Programs for the Elizabeth R. Griffin Foundation and was the team leader to Nigeria and Liberia and Sierra Leone for the Ebola outbreak response activities. He worked extensively in Afghanistan and Iraq with Defense Threat Reduction Agency Cooperative Biological Engagement Program as a consultant to CRDF Global and Landell Mills UK. After serving in the Australian and British militaries, he was selected by the UK Department of International Development for the Associate Professional Officer Scheme. He learned epidemiology as an epidemic intelligence service officer at the U.S. Centers for Disease Control and Prevention and was a global health fellow at USAID. Dr. Macgregor-Skinner holds a Master's of Public Health with a focus on epidemiology from Johns Hopkins Bloomberg School of Public Health and a Master's of Science in Wild Animal Health, Emerging Infections, and Zoonotic Diseases from the Royal Veterinary College in London. He has a Bachelor's of Veterinary Science with a focus on veterinary medicine and surgery from the University of Queensland in Australia and is a member of the Royal College of Veterinary Surgeons. So with that, I introduce to you Dr. Macgregor-Skinner.
Thanks, Steve.
I got to take a deep breath.
Good morning, everyone. Let's sort it out. Right, for the faculty that are here, I'm going to go through some experiences that I've personally had in my career, and I want you to think about the examples I give you, how would I teach this? For the students, where are the students? For the students that are here, these are real-world experiences, and I want you to start thinking, how am I going to learn this, and who among us is going to teach and exchange that information, that knowledge, so that I have the necessary skills and competencies to be deployed for a disaster or an emergency. I want to start with public health emergencies of international concern. International Health Regulations 2005. Since then, we've had 4. April 2009, H1N1 pandemic. May 2014, the polio resurgence. August 2014, Ebola. February 2016, wasn't Zika. The emergency was clusters of microencephaly and Guillain-Barré syndrome. But I want you to focus on this picture by Jerome Day. This is a situation that I found myself. I had 3 deployments to West Africa, 1 to set up Ebola hospitals, 2 to train the staff, and 3 to be the supervisor or manager of those hospitals. They're wearing yellow PPE. We never wore yellow PPE. Why are we wearing yellow PPE, personal protective equipment? Because the people in this village, this community, related the colour of white to what? Death. So we had to acknowledge what the community wanted. And you know, yellow personal protective equipment costs more than white personal protective equipment. This blew my budget. We're leading a child away. How much did we know about Ebola in children? Nothing. How many paediatricians did we deploy with? 0. What don't you see here? You don't see the hundreds of people behind, family, mums, dads, relatives, and the community screaming and yelling at us and crying, why are we taking this child away by these 2 physicians leading them into the ambulance? What did the little girl have? Fever. What else did she have? Fever. She met the case definition for Ebola. We're in the middle of the world's largest Ebola outbreak. So where is she going? The Ebola hospital. She's either going to live or she's going to die. Well, I want to take you to World Health Organization's report. They came out with weekly reports. This is the 5th of March 2015. Why is it important about the case definition? Because when I had my 3 deployments to Nigeria, Liberia and Sierra Leone in 2014, anyone with fever ended up in the Ebola hospital. We received results on my 2nd trip from the Ebola hospital. We had 210 patients at that time. It took about 4 to 5 days to get the results back from real-time PCR. Of the 210 patients we had, 120 were negative on real-time PCR for Ebola. Is that a problem with the test? Some quality? Possibly. Did they have something else? You betcha they did. Did I give them Ebola? Yes, I did. In my hospital. 120 out of 210 were negative, but it took us 5 days to get those results back. What do you do? I also want to illustrate here in Sierra Leone. On the week of 22nd of February, 1,518 people came to the hospital with fever. 6% of those were tested by real-time PCR and had Ebola. What happened to the other 94%? They received no treatment whatsoever because we're in the world's largest Ebola outbreak. We don't know what they had. We missed cholera, we missed typhoid, we missed E. coli, we missed influenza, we missed Marburg and Lassa and all the other stuff that we're now going to start to catch up with. What did they have? And this was happening on a daily basis. We couldn't even fix a broken arm in Monrovia, Liberia at the height of September of 2014, where we were getting 60 Ebola patients a day. All the schools were closed, the markets were closed, we were under a government curfew, and we couldn't fix a broken arm because everyone had left and gone to the Ebola hospitals. I want to take you back to July 2014. Randall Shop and Cynthia Rossi work up at Fort Detrick in Frederick, Maryland, published a paper. They went back to a Lassa fever outbreak in Sierra Leone in October 2006 that lasted about 6 months until July 2007. What they found was that the known patients that we thought had Lassa fever actually tested for dengue, West Nile, yellow fever, Rift Valley fever, chikungunya. Oh, there were Ebola patients back in 2006. And Marburg. As we get lots of Lassa fever outbreaks. I've been on many Lassa fever outbreaks in Nigeria, Liberia, and Sierra Leone, and Guinea. Have we come up with this differential diagnosis before? No. Have we treated patients appropriately? No. If it's a cholera outbreak, we're treating cholera. If it's a Lassa fever outbreak, we're treating Lassa fever. If it's Ebola, we're treating Ebola. But I also want you to reflect on the number of healthcare staff, doctors, nurses that died. On my second trip to Liberia, I was sent to a hospital where 24 doctors and nurses had died. I arrived, we had about 210 patients, we had about 170 staff, and I said, today we've got to stop work. Well, no one said, no, we're stopping work. We've got patients to deal with. No, you've just lost 24 doctors and nurses. Do you know what that means? How long it takes to replace? Plus, we've lost people we knew have died from this disease. Overall, 881 cases just within doctors and nurses. Not the burial teams, not the admin staff, not the ambulance drivers. It's just doctors and nurses. 62% of those died, 513. But that's not the only time we've had this happen. SARS back in 2003. Total cases worldwide, 8,273, 775 deaths. Hospital staff treating patients in hospitals, 1,760, or 21% of the total cases were hospital staff. Hong Kong, 360 hospital workers contracted SARS. Toronto, Canada, 74 cases directly from exposure in one hospital alone. Why? Lack of management, poor supervision, lack of training, lack of an understanding of culture of safety. I'm also going to talk a little bit about high reliability organisation principles and how we're not just teaching those in hospitals now, but we're teaching those in universities to medical students and nursing students. That really happened. And to show that really happened, here's the epidemic curve from that Toronto hospital. The dark squares are the patients from outside the hospital. The grey squares are the hospital staff. Here we have the first epidemic curve. Then on April 27th, the Canadian government said the outbreak's over. No more extra time payment, no more overtime payment, no more using personal protective equipment, do away with the N95s, the gloves, the suits, no more money on anything, and they stopped. And what happened? We got a second epidemic curve by hospital staff. We work in high-stress situations. The hospital is stressful. It's busy, but it's also very, very dangerous and high risk. Quick, it didn't come, but this is a map of the US. This was published on the 31st of July 2014 in the New York Times, where it showed the public health laboratories in the US that could diagnose Ebola and the hospitals that had been designated to accept Ebola patients. When I show this to my 2 children, what's the first thing they say? Hey, Dad, the dots don't line up. So what do we need to focus on? Our transport systems. How are we going to move patients to these hospitals? How are we going to move samples to the labs? And no one did that. And when it had to happen, we went to critical failure again. So why should we care? Well, we know diseases spread further and farther now today, and we've seen that on a regular basis. We know that from the International Health Regulations of 2005, the Global Health Security Agenda that was launched in 2014, we've done over 65 country assessments now, where we do a self-assessment and we go in with teams to help them come up with the capabilities, the skill sets and the needs and resources that are required to meet the International Health Regulations. 70% of those countries are not prepared. And then we know what motivates people for us to do the training, the education, because SARS cost us $40 billion, Ebola cost us over $30 billion. The gross domestic product of Liberia was at 15.6%. By the end of Ebola, it's at 2.4%. So we're dealing with an unseen enemy. Makes our job really challenging and very difficult. From uncertain sources. And those uncertain sources is that we don't have processes or systems on how to do surveillance, triage and testing. We saw last week EK203, Emirates airplane, land at New York Kennedy Airport. On that plane, 100 people complained of fever. By the time the plane landed and they saw what they went through, only 20 said they had fever. Of the 19 that allowed testing, 9 refused to go to hospital. 10 of the 10 that did go to hospital and were admitted, 7 of those were staff, were the flight attendants. Only 3 passengers out of the 100 actually followed public health guidelines and the recommendations of the New York City Department of Health and CDC and went to hospital for follow-up tests. 3 out of 100. I'm going to cover a couple of myths today, 7 myths. First one, we know how to communicate risk because we've come to medical school or we've gone to nursing school and we've learned how to communicate risk. And so that when we had the Zika virus outbreak, when we saw Zika go out, the World Health Organization said, let's colour in, let's get our colouring pencils out and colour in these countries because that conveys risk. What did the governor of Texas say? Don't you dare colour in Texas. But we did. It conveys nothing. The size of Brazil shows absolutely nothing when we colour in the same colour for all of Brazil. The populations, the diversity, the geography. It conveys no information whatsoever. It doesn't help us medically and through a public health lens decide what to do next. This is Atlanta Airport. One of my jobs that I had for Zika was to travel through airports and seaports, ports of entry around the world and look at how they were conveying risk and communication. Down in Atlanta, one of the world's busiest airports, the CDC, the Georgia Department of Health had put these signs up, Zika virus, protect and prevent, if you've been to one of these countries. How good are we at geography? I know I live in Washington, D.C., not very good. Can we identify all those countries there? Nope. We often go on vacation. We still don't know geographically. We can't put a pin on the map where we actually went. And so I went back to CDC, the Georgia Department of Health, and the airport authority and said, this is worse than useless. And they said, no, Gavin, this is great. This is our communication strategy. I said, show me the data. Show me where the number of patients or the number of passengers that have read this and taken some sort of action. How many did they have? 0. Couldn't show me anything. CDC in Zika. CDC publishes a map. Here's the website on September 7th, 2016, and they put red rectangles over a map of Miami-Dade County. What do you think about that? If you live down in Miami-Dade County, don't cross the street and go into the red rectangle because that's where the Aedes aegypti mosquito is and it's going to bite you and give you Zika. Stay on the other side of the road. How many of us within the medical profession said, CDC, don't do this? Not many. We went to meeting after meeting, don't do this, don't do this, don't put red rectangles on maps. But Fox News and CNN are a little bit smarter than the rest of us. So they go to Google Earth and get satellite imagery and start honing down to the houses that are inside the red zone. Then they go out and interview people from the red zone going, how do you feel about being in the red zone? Then I went on TV and I was asked, well, why are Americans so scared of Zika? I went, really? And we went through, don't do the red rectangles. Don't allow CNN and Fox News to go to Google Earth and say, your house is inside the red rectangle. How do you feel about that? When are you moving to St. Maarten, for example, to get out of the red zone? We don't do this. And not enough of us within the profession stand up and say, don't do this, because we're smarter than that. This is Emory University Hospital. For Ebola, I was the checklist guy. Now, what that means is that for the Ebola patients that came to Emory, I would stand in my personal protective equipment in the room with my checklist looking for breaches of security and safety, looking for mistakes, and then I would correct them on the spot. The risk was that high. Patient number 3, Ian Crozier. We shouldn't know his name, everyone. HIPAA. My kids are going, Dad, how's Ian doing? How's Kent Brantley doing? Guys, you should know his name. Oh, it's on the news. There was no patient privacy. Ian Crozier, patient number 3, first patient to have a central line put in, on dialysis for 41 days. I was part of the team that sat down and looked at the dialysis with the team at Emory going, can we put an Ebola patient on dialysis? Do we need to write off the piece of equipment at the end? What do we do? How do we clean it? It took us 30 minutes to do our risk assessment. But even so, even at Emory, they have, don't take your guns in. That's a good one. No smoking. And then this little sign up here. If you've had a fever and you've been to the following countries, go and tell someone. So I said to the valet, how many people read that sign? No one. So I said to the security guard, who's armed and stands, how many people read that sign? No one. So I said to the receptionist, how many people have come and said, hey? No one. But the hospital executive board and the administration said, we're doing our due diligence. This is how we convey risk. So then I went over to Tennessee Medical Center. And I walked into Tennessee Medical Center, and they said, if you've travelled to one of these countries in the last 30 days and you're not feeling well, please let a hospital representative know immediately. And I went, oh, we're going to have some fun with this. These signs were all through the hospital. How many staff are at Tennessee Medical Center? 5,000. There's 5,000 staff. I went across to the medical school. I rang up the hospital, and I said, we're going to do an exercise this afternoon. And they said, no, Gavin, exercises take months and months to plan, and we haven't planned this one. I said, we're doing an exercise at 1:30 at 1:30 this afternoon. I went over to the dean of the medical school and said, we're doing an exercise at the hospital, level 1 trauma centre. This is what we're going to do. I need 25 med students, and they're all going to take on the role. They've just come back from Liberia, and they've all got a fever and some aches and pains, and they're not feeling too well. And then we're going to scatter throughout the whole hospital, and we're going to do exactly as the hospital said. We're going to look for hospital representatives. Hospital representative looks like what? A gentleman in a white coat, someone in scrubs, someone with a name tag on. We're going to grab them all. How long did my exercise last before we had complete chaos in that hospital? 15 minutes. I got the call, stop the exercise. I thought so. That doesn't help us. It might make the hospital administrator feel really warm and fuzzy inside, but us as frontline health workers, it does not help us. And not one of the 5,000 staff at the hospital said, I think this is worse than useless. And then they changed it. They developed an app, they started handing out things, they started engaging with people instead of putting signs all over, if you've been to these countries, go and grab a hospital. It didn't work. And it happened recently. The myth of the Maginot Line. Maginot Line in World War I was where the French set up tanks, concrete, machine guns and said, if we put all this in place, we're going to slow down or stop the Germans. Did it work? No. We often do this in medicine and healthcare and health systems all the time in our hospitals. We think if we have that building and have that isolation room and we have these standard operating procedures in place, we're going to save the world. It didn't happen. Seema, Yasmin, Wolf, and myself were on, and we're talking about the new CDC guidelines. Why had so many hospitals not started to prepare for Ebola or any other highly infectious disease? Because they were doing what? Waiting for the CDC guidelines to come out. And I said, no. We've dealt with SARS. We had pandemic H1N1. We've had all these other, we do measles every year. We have seasonal influenza. Do your risk assessments. No, we're waiting for these guidelines. Did anyone read these guidelines? 30 pages. I stopped reading them when they got to version 17. I have all 17 versions on my desk just to show my students what they look like. You needed a PhD to understand these Ebola guidelines. Not one photo, not one diagram. Where were the clinical algorithms? Where were the flow diagrams? Where were the decision matrices? They weren't there. And they came out. And then I had all these hospitals spend lots and lots of money on stuff they didn't need. For those who haven't seen an Ebola hospital, this is what one looked like in West Africa. This is Moyamba. I did not work in these. These started to be built in the last week of November, the first week of December. I did my first trip in September, my second trip in October, my third trip in November. By then I was burnt out. Plus it just got too political. My kids had been kicked out of school in DC. I'd been told I could no longer train the soccer team, the school soccer team, which I'd trained for nearly 7 years. My family were no longer invited to parties. I got told by Penn State, don't come onto campus until further notice. And now I was done. And that really happened. This is Moyamba. 200 patients, 624 staff to run Moyamba for 200 patients. Waste management, liquid management, solid management was really challenging. Feeding the patients, feeding the staff was really challenging. And the worst thing is that we're on the edge of town, and what are we seen as? The stormtroopers, the bad guys. If you were in there, you could not leave. My hospitals, the hospitals I set up were in a hospital, and the other ones were in schools, where the schools had all closed down for 10 months, and we set up the Ebola hospitals inside schools. Again, CDC came out with preparing US hospitals for Ebola. Tom Frieden, the director of CDC, said every hospital in the country should be able to deal with an Ebola patient. No way in the world. And that's a simple back-of-the-envelope exercise. We went through hospital preparedness, a tiered approach. How can you start building a tiered approach in the middle of a crisis and an emergency and expect everyone to understand it and then expect to have the resources to implement it? It didn't work. Anyone been to Emory? Okay? So there's the patient, there's Gavin standing in the corner, the checklist guy. That's where I stood. And Patty did the same, Kalpana did the same, Clay did the same, as we took turns to be the checklist guy. These are the two patients in those two rooms there. Is it built to textbook? No. Why? There's no clean way in and there's no dirty way out. But did it work? Yes, it did. Anyone been up to Nebraska and seen their biocontainment unit? So they were able to take, Emory could take 2 patients. If we doubled up, we may be able to get 2 patients per room, but that would be really impossible. So their limit was 2 patients as the National Ebola Treatment Center. Nebraska had 10 patients. Is there a clean way in and a dirty way out? No. Is it built to textbook? No. Did it work? Yes. Through good management and good supervision. The challenges we had with here is that many of the staff that I worked with at Emory, the nurses and the physicians, lived in gated communities around Atlanta, and those gated communities said, don't come home. They lived in apartments, and the people in the apartment block said, don't come home. Saw you on the news, don't come home. Suddenly we've got 48 hospital staff that we now have to find a place for them to live, sleep and eat, where everyone else is, you're one of the Ebola nurses, you're one of the Ebola docs, don't come home. I went to London, and in London, this is the Royal Free Hospital. This is their Ebola treatment unit. We're seeing these being used right now in the Democratic Republic of Congo, these biobubbles, these modular systems. Royal Free treated Ebola patients. Did they do them successfully? You betcha they did. It's a system that's been around for a long time for highly infectious diseases, wasn't used here in the US, being used in the UK and other countries, and now being deployed in the Democratic Republic of Congo. Allows you to access the patient without putting on the full personal protective equipment. What I found unusual, the number of hospitals I went to when I looked at their floor plans, the lack of risk assessments, the lack of thinking of how they would move both patients under investigation, suspect patients throughout their hospital. And this is one of the plans that was sent to me when I was working with healthcare coalitions in 5 states. Will this plan show you what you need? That came from the hospital executive board. They weren't thinking. There's 16 entrances on this map. How do we stop the Ebola patient from just coming up in a car, an Uber or a taxi, getting out and going through one of these entrances? Because their plan said that they were all going to come through that main area there and go into the emergency department and meet the receptionist, and then they're going to be escorted off into their special isolation room. It's not going to happen. And it didn't happen. Risk assessments. I teach a lot of medical students risk assessments. We are doing risk assessments all the time. As we start to develop what is that, identify what that culture of safety is, it's not just patient safety. As we start to implement principles of high reliability organisations, we are doing risk assessments all the time, and the only way we'll get the hospital executive board to give us money is if we can show it visually. So we take those risk assessments, about 96 questions, and we show it visually and go, this is not working, this is working. This is where I need help, this is where we're doing okay. So much so, the 14 countries we went to that were contiguous to Sierra Leone, Guinea and Liberia, we ran risk assessments. And no one wanted to read the reports. No one wanted to read it. So what we do, we created public dashboards through WHO, this is from the World Health Organization, that showed using the traffic light scheme, red, yellow, green, with a percentage of how far they've come along on how prepared those other countries were. And it's what we still do today under the Global Health Security Agenda. Show visually to decision makers, are we ready? No. What are the gaps? What do we need? It's Tim Trevan and myself. This is the first team that we trained in Nigeria. I was paid for by Nigeria. I ran a foundation called the Elizabeth Griffin Foundation based in Kingsport, Tennessee. When the Nigerian government transfers nearly $250,000 into your very small bank account in Kingsport, Tennessee, and I live in Washington, D.C., people within Washington, D.C. that I do not want to meet come and knock at your door. So I had a phone call that day from the bank manager. Gee, we've got a lot of money from Nigeria. It's a scam. Don't believe it. FBI, CIA, other intelligence agencies that I've never met before, ever heard of, came and knocked at my door and went, what's going on? I rang Dr. Parker in Nigeria because he'd come out to Emory and CDC with a plan. Emory had said, we can't do that because you've got too many limited resources. CDC said, no, forget your plan for Nigeria, follow this plan, which wouldn't work in Nigeria. When I came down at the meeting, I said, we'll make whatever you have work to be safe. Dr. Parker transferred $250,000 to our small bank account. That was a learning experience. Then he said, can you have your team here tomorrow? And I said, no, but I can be there in 2 days' time. I picked up the phone. There's been a businessman in a Florida hospital with MERS. I rang that hospital and said, I need nurses and physicians that have had experience with dealing with that MERS patient. I'm going to pay them this much, and we're going to Nigeria. That's where I got my first group. Tim and I had been working together for years. This is our first lot of nurses that we trained. It was a Wednesday in September. It's 10 o'clock in the morning. We get the phone call. You're getting your first Ebola patient. What do you do next? You stop and have a cup of tea. The Ebola patient came, we offloaded. That lady on the left-hand side that's not in white, her and I went in that night. She got vomited on. And if you haven't seen an Ebola patient, you'll see more diarrhea, if you have dreams like I do, that you can never imagine. More diarrhea. I can't even describe how much diarrhea you'll see for an Ebola patient. And you'll see projectile vomiting like you've never seen projectile vomiting. She got vomited on. What do you do when you're in your personal protective equipment and you've just been vomited on by a patient with Ebola that has a disease that has no cure? You yell, you scream, and you start to get it off. You start ripping it off. I'm in there in my PPE. She's much larger than I am, and I'm trying to wrap my arms around her to control her and stop her. We were not trained for this. Tim takes over, gets everyone else in PPE, they pull us out, they strip us off and throw us in the showers, and we get decontaminated. Someone had to take control. Tim took control. Because when I put my arms around the lady and I could smell the vomit, I started crying and yelling and screaming. I lost control. So now we bring that into our training. What really happened? We slipped over all the time. We went in with white PPE, we came out with grey PPE because we're on our backs half the time. It's so slippery on those concrete floors. How do we get to that level of training that I've been talking about? Here's a project that I'm doing in India with nurses and physicians. This one's actually for physicians. We take cell phones and we put a years-long training from the College of Physicians and Surgeons, and we put it on a micro SD card. Each person has a unique identifier, and they can do the whole course on something they carry every day. And we just hadn't thought of this big enough. And it's very low cost, but now the College of Physicians and Surgeons now acknowledge that that's their continuing medical education if they do it on the cell phone. And they hand in the card at the end of the year. I'm going to talk about a myth of simple divisions of a stockpile, which is a big mistake we made in so many areas. I've been wearing PPE for nearly 20 years. Bird flu in Indonesia. Outbreaks of other diseases that we just didn't know. We didn't have a laboratory diagnosis, but patients had fever, and we had no idea what we were dealing with. We've looked like this for a very, very long time when we deal with a lot of different pathogens and diseases. Texas Children's Hospital published on March 30th that these were the original CDC guidelines. No, they weren't. Then they said CDC then changed their guidelines. No, they didn't. What you didn't do, Texas, you didn't do your own risk assessment. You didn't sit down and work within our building where we work, what would be the risk inherent if we got a high infectious disease patient? And that's where the mistake was. I was a professional witness. I spent 8 hours in the stand when the trial for the two nurses came up on what happened there, and I was grilled for nearly 8 hours. Why don't you wear this? Because we do our risk assessment. And we know when we're treating with a disease with no cure, like Ebola, I don't want any part of my body exposed. If you hold up your thumb, a patient with HIV that dies has 300,000 virus particles with a spot of blood that covers your thumb. An Ebola patient that dies has 10 million virus particles on that spot of blood on your thumb. That's the risk we're dealing with. This is in Tennessee, and I want to emphasize, I got paid a lot of money to teach people how to put on and take off PPE. It's not about the PPE. At this particular workshop, 34 hospitals turned up with 34 different combinations of PPE. It looked nothing like CDC. Did we make it work? Yeah, we did a risk assessment. All except for this one here on the right-hand side near the American flag, where they had the ladies wearing the largest battery packs I've ever seen, and they just couldn't move. I said, show me how you draw blood. Show me how you clean up the spill. Show me how you do this. We can't move. So I went back to that hospital administration and said, these ones won't work. The other 33, I'm going to write standard operating procedures particular to the equipment that you have. We're not going to follow the CDC guidelines. We're going to use them as the backbone, as the platform, but we're going to write specific guidelines for what you have. I don't wear an N95 mask anymore. Anyone been tested for an N95? Got your certificate? Everyone fit tested? When you get fit tested for an N95, you get a little certificate, and it says you have been fit tested and you're certified to wear this particular model. How many times have I been deployed on an outbreak and that particular model of N95 has been sitting there in the hospital? 0. So I wear another one that I actually failed on, or I take my own. I now wear PAPAs, and this is a Nipah virus outbreak. CDC staff wearing a PAPA. This is what I wear now. I've got about 20 of these at home, and if I deploy, I don't take the risk anymore. When you've gone to a hospital where you've lost 24 doctors and nurses, and it's because we had poor equipment or poor management, poor supervision, we're now wearing PAPAs, and we train in PAPAs. And I can work in this for 3 to 4 hours. I can only work in an N95 for about 45 minutes, and then it's too much. Let's not forget, though, Fatu Kukula, because she developed her own protective gear in Liberia with plastic bags, and she actually treated 24 family members that were all Ebola positive and had Ebola disease. And she wasn't the only one. There was hundreds of these women that did this, that did their own without any medical training. She had no medical background, did their own risk assessment and said, if I have to protect my eyes, my nose, my mouth, and my skin, what am I going to do? And they made them at home in the markets. Myth of how clean is clean. Bleach. WHO says use 0.5% bleach on equipment, 0.05% on you. What did we get at the market? 8.25% bleach. Every medical student, every physician, every nurse knows how to dilute 8.25% down to 0.05. It didn't work. Oh, okay, so today we've got 70% chlorine as a powder. Let's dilute the 70% chlorine down to 0.05%. It didn't work. Our metric here was, Gavin, we need to spray you again because you don't smell strong enough. I lost my sense of smell, my sense of taste. I came home on my third trip and my wife said, hey, let's go get the biggest steak you can find because you've been eating, you've lost 20 pounds of weight, which I did. I couldn't taste a thing, I couldn't smell a thing for weeks. Anyone seen one of these? Vaporized hydrogen peroxide. This is what Emory in Nebraska used for their Ebola patients. When you have an Ebola patient in a room, we lost staff. Nurses didn't turn up, and they didn't even work on the Ebola ward. They worked over in labour and delivery, or they worked over in the ER or the OR. They worked somewhere else. They didn't come to work. Physicians didn't come to work. So we used vaporized hydrogen peroxide or chlorine dioxide. What's the biggest thing we have to show everyone in the hospital? Visual indicators. And there were no guidelines for visual indicators. So we can use a hydrogen peroxide vaporized generator. We do our assessment of where we need to position them, and then we can use a chemical color changing reactant, which shows that it was reached the right concentration, the right contact time, or we can do 7-day incubation and show that it worked. We can't wait 7 days in a hospital. And there were so many people in Emory University Hospital said, we're not going to use these rooms ever again because they had Ebola patients in. It took months. The myth of where we are. What we don't do enough with our medical students is teach them situational awareness, teach them how to report on geographically where they are. And in 2016, the Joint Commission said, and we all knew that everyone was doing this, let's end the text messaging ban for clinicians. Well, everyone's been using text messages in hospitals for years. Why don't we even take it one step further and actually use the media platforms we have now, which are 256 AS encrypted or 140 FIPS, which is beyond HIPAA, and we start to operationalize those in our hospital settings. So a lot of people use what's called Tiger Text. I know all the nurses in Pennsylvania, Georgia, Tennessee, Alabama are texting all the time using Tiger Text because it's HIPAA compliant. But have we trained them? Have we taught them how to use it effectively in a hospital setting? No, we haven't. But if you came with me on the Ebola outbreak, you were required to text me 20 times a day with real information that I needed, situational awareness, and that required more training. We don't train in the hot zone, but we did. We didn't have maps. This is in Monrovia. This is what we had before, and these are all the different organisations that got together over a 7-day period to produce that map. We couldn't identify where the patients were coming from. We couldn't locate them to follow up them. We had to, all the contact tracing was 21 days, take the temperature twice a day. Our first 3 patients in Nigeria led to 819 close contacts that we had to follow for 21 days. What on-the-shelf product do we have in our hospitals to do that? Or does public health have? So we use now what 3 words? It's on the cell phone. I do a lot of my teaching at Penn State Hershey and other medical colleges I go to, how to use your cell phone in a disaster. And again, they've divided the world up into 57 trillion, 3 metre by 3 metre or 10 feet by 10 feet squares, and every square has a unique 3 words. The country of Tonga is 36 islands. Its postal system now uses 3 words. I went to Tonga after Hurricane Gita, and everything Every message that went out had a 3-word address on it because you're going to go to the right 10 feet by 10 feet square. And we're now actually teaching it within the hospital and teaching it to our physicians and our nurses how to create situational awareness with free tools that are available on your phone. So that women like this can have an address. 85% of the population in Nigeria does not have a physical address. 95% of the population in Liberia when I was there did not have a physical address. How do you do patient follow-up? How do you identify where the risk is? We couldn't do it. We do a lot of mapping. We found that the border of Nigeria and Cameroon was being used on a regular basis for people to go to work or go to the market, and this was a crossing. Now, the World Health Organization said, we need to close this down. And we said, no, we don't. What we need to do is build a health clinic right at the edge of this crossing, and we just start to engage with the community. Because this is a remote sensing satellite imagery, and we can see it's a well-worn track. A population we couldn't get to. So we built a health clinic, a little kiosk, where we could then start triaging patients on a daily basis. Population risk mapping, again, using drone video and remote sensing, we can identify how many of the houses were slept in last night, so that we have actual population census data to do our risk analysis. UAVs in global health. In health, we don't call them drones, we call them UAVs. US government's very clear on that. If we're using drones in a health situation, they're UAVs, Gavin. We've been doing it since we started a number of case studies that were published recently in a compendium of 50 case studies, going from delivery of medicine and other supplies in DR Haiti to testing of dropping off samples and picking up samples in Uganda and Malawi and other places. You, as the physician on the ground, the drone operator will come to you and say, what do you want me to do with my drone today? And if you aren't aware or you know what the capabilities are of those drones, then it's not going to happen. Here's a two-way system that we use in Rwanda, Uganda and Kenya now. Flies out about 110 miles and it gets landed, and then another launch site sends it back. And we're using that for HIV, TB and malaria programs. Where we're headed, we work in fragmented systems. We're now thinking more along systems of systems, how to teach systems thinking to our medical students. We're looking at how to make functional, interoperable systems. If something happens in the hospital, there's always a cascade of events that happens after it. We don't think like that. So the case studies, the exercises that I conduct is all about systems thinking. Design thinking at the multi-level management level. We had a real failure in yellow fever, cholera, Ebola, Zika, chikungunya, dengue on how to do multi-level management within the healthcare system. The exercises that I do are 15 to 20 minutes long. It's a case study on a real-world example. How would you make decisions in this situation? We've gone from not just following what JACO says and do one exercise a year. We're developing now comprehensive exercise management plans in hospitals in Lehigh Valley, over in Nashville, down in Georgia, Atlanta, Georgia, over in Mobile, Alabama. So the hospitals are doing exactly what I did when I had my 12 years in the military. We're exercising all the time with what-ifs. We're building up that culture. Here's a framework that TB, again, has utilised in exercises, but also in technology, using video on demand, using cell phones, again, to develop capacity and competencies and skill sets. Identity. How often do we teach within our hospital how to identify our staff and how to identify our patients? Of the 24 doctors and nurses that died in that hospital I went to, over 3/4 of them were John Doe and Jane Doe.